Good morning, good afternoon, and good evening, everyone. Thank you for joining us for our first Global One Health Initiative webinar of the new year, supported by the NIH Fogarty International Center. We are very excited to have our own Global One Health Initiative, or GOHi Executive Director, Dr. Wondwossen Gebreyes, present on the GOHi strategic vision and current activities. And we are also excited to have our director of our Global One Health Eastern African office in Ethiopia, Dr. Getnet Yimer Ali, serve on our panel discussion. So I'd like to start off by providing a brief introduction to our speaker. Dr. Wondwossen Gebreyes holds a doctor in veterinary medicine as well as a PhD, is a founder of the Ohio State University Global One Health Initiative, a Hazel C. Youngberg Distinguished Professor of Molecular Epidemiology in the Ohio State University College of Veterinary Medicine, and conducts research on globally important zoonotic and foodborne diseases with an emphasis on antimicrobial resistance. Through his leadership, Ohio State has formed partnerships among hundreds of students, faculty, and staff, and international organizations working in diverse fields to improve health, build capacity, and provide learning opportunities for students across the globe. And he has been recognized for his innovative academic leadership by renowned institutes, including the APLU Michael P. Malone Award, NIH Gold Medallion, Universitas 21 Award, and the IIE Andrew Hiskel Award. Following nomination by the senior administration at The Ohio State University and a rigorous application process, Dr. Gebreyes was recently selected to be one of only 38 American Council of Academic, or ACE, fellows for the years 2020 through 2022. And he was recently inducted as one of the inaugural leaders of the American Academy of International Education, composed of 20 distinguished university leaders. And with that, I'll go ahead and let you share your screen, Dr. Gebreyes.
Great, thank you so much, Dr. Binkley. Very much appreciate the generous introduction. Good morning, good afternoon, everyone. Do you see my correct slide, PowerPoint?
Yep.
Okay, great. So I will do it on presentation mode. Happy New Year to all of you who celebrate the New Year in January. Some countries, including Ethiopia, the New Year starts in September, but to majority of the world, Happy New Year. Great to see everyone. Delighted to be here today. Dr. Binkley asked me to share what Global One Health Initiative is currently doing, where we are as a team of experts, faculty, staff, but also the wonderful global partners across the strategic areas, ranging from the state of Ohio to East Africa, Latin America, Asia, what the partners are doing. So today I will share with you a presentation, a short presentation prepared by a team of directors. Global One Health Initiative has 4 wonderful directors: Dr. Amanda Berrien, Director of Outreach; Dr. Michael Bessesi, Director of Training, Capacity Building; Dr. Siwang, the Director of Applied Research and Implementation, Capacity Building; and Dr. Getnet Yimer, our Eastern Africa Regional Director. During the panel, we'll be joined by also Dr. Desalegn Mengesha, the Associate Director of our Global One Health Eastern Africa Regional Office. Excuse me, just to share with you quickly why GOHi, Global One Health Initiative, exists. Why are we on this planet? It's because of the vision we have, what you see on the left-hand side. We have identified that there is a major gap of capable and impactful institutional systems, which includes professionals, infrastructure, others, that support and advance healthy and enduring global community. That is clear gap throughout the world, particularly in the developing region, but clearly, as you all have seen in the COVID-19 pandemics, even Western world, including the United States, we still remain having a major gap of institutional systems to prevent, if possible, or better be prepared and mitigate epidemics and pandemics. But our goal is beyond that. So enduring livelihoods and also beyond infectious diseases, the non-infectious chronic diseases at the interface of human health, animal health, environment, plant health aspects, including chemical hazards and other issues. So in order to realize this vision, we articulated back in 2017-18, we really revisited our paradigm and developed strategic goals. Our core strategics are 3 areas to achieve this vision: strengthening, building or strengthening training and education capacity using this mechanism. Second is really expanding applied, particularly in applied translational research and implementation science capacity. And the third is outreach and community engagement and what we call extension in the US, within the US system capacity. And then the 3 core goals are supported by also very important 2 supportive goals. The core goal supported by resource stewardship goal and financial sustainability. Those are all critical and we held it dear at our heart. You all know the One Health system. You saw different schematics, diagrams all over the world. What you see on the left is what we feel, but regardless, the key emphasis is the interface of human health, animal health, zoonosis, the interface of animal health environment, the interface of human health environment, or the whole dynamic. So to me, One Health is all around this, any of the interfaces in between 2 areas, all the 4 areas. So One Health is not just this part, but really inclusive of that central component. So our emphasis, our focus is on that. Anything outside of that is not really fit with our global One Health paradigm, but we are anchoring, particularly being a university-based, our emphasis is not on regulatory issues or other innovative discoveries, but building capacity, capable professionals and institutional systems. You can find a more detailed report on our website. It's indicated here, the full 4-year report released about a month or so ago on globalonehealth.oscu.edu website, and thankful to our outreach manager and senior program manager, Ashley Barsani, and monitoring and evaluation expert here, you see Saira Nawaz, but it's always a teamwork. Anything we do is a teamwork. Here is a very crowded slide. I'm not gonna get too much into the weeds, but this really represents our model system to achieve our vision here, capable professionals in the institutional systems. As I said, the core areas, training and education capacity. We often start with a needs assessment, be it Africa, Latin America, heavily we emphasize on Brazil or some Caribbean countries or Mexico, or Asia, Thailand and others. We conduct short and long-term process, as you see in the blue, summer institute, curriculum twinning, and then longer-term PhD and personnel, things like that. What we do in that strategic goal is building critical mass of trained professionals. But capacity building is not equal to training, please. Many times I see people equating capacity building with training. Capacity building is not just training. We also look at the scientific qualities, infrastructure, laboratories, and other things. So what you see on red is the second strategic goal on applied research and implementation capacity. Some of the areas we work are listed. There are many areas I did not list, but more of representative interfaces. Food safety on zoonotic diseases, such as rabies. We have been working on rabies, brucellosis for a long time, salmonella. I myself have been a salmonella researcher. Antimicrobial resistance, what you see on the next here, is on infectious and non-infectious communicable diseases as well, including coronavirus, COVID work. Maybe we get into during the panel discussion more in detail with Dr. Getnet, and many of our internal medicine experts are leading COVID-19 projects. And then these issues, what you see on the red, but on the right-hand side is building the molecular diagnostics, genomics capacity, genotyping capacity that we've been doing since I would say since 2010, with East Africa through NIH program, which also sponsored this webinar on a monthly basis, as Dr. Binkley stated, but also in Mexico, had a great molecular epidemiology program established on food safety in partnership with the US Department of Agriculture and Autonomous University of Mexico. And Federal University of Paraíba also, strengthening the genomics capacity together with the university in Paraíba, but also with Food and Drug Administration in Maryland, and so on and so forth. And then hospital-based diagnostic stewardship, clinical specimens collection, and others as part of our global health security agenda work we do in partnership with Centers for Disease Control and Prevention, CDC, and others. In our third portfolio of core goal is outreach, community engagement, extension capacity. This is where we use opportunity through the training and research and knowledge sharing, really enabling people become aware of the key priority one health issues, and conducting workshops, subject matter workshops specific. We do a lot throughout the year. Global One's initiative webinar, where we are today, is exactly what I'm trying to do, is sharing our model and sharing some of the knowledge we do. We held every other year Congress, we used to call it until this year, ICOFA, International Congress on Pathogens as a Human, Animal, Plants, Environment Interface. ICOFA Congress, quite a few of you on this webinar have been great participants starting from 2011 on every other year basis. As of this year, the executive body, the global partner body, renamed this as Global One Health Conference. So you will hear more about that soon. So collectively, through these three core goals and additional resource stewardship, others, we host visiting fellows, strengthen MOU partnerships, electronic capacity building, library resources, you name it. Collectively, we achieve this: workforce developed, laboratory, hospital, field capacity, surveillance, others built, knowledge shared. That's what we believe in how we can build capable professionals in institutional systems to prevent the future COVID-19s and others from occurring, COVID-likes from occurring. So it took quite a bit of time. So I will walk you through as an example now. I'm not going to take much time, but I hope we'll have more enriched panel discussion. But just to give you some examples from our training capacity, Summary Institute you see on the left here, but we also do curriculum twinning over the summer. Since 2012, we have been hosting a number of face-to-face between 2012 2019, and this past summer, digital, virtual Summary Institutes, mainly hosted in Eastern Africa, participants from various African countries, particularly Ethiopia, Kenya, Tanzania, but this year being virtual from about 47 countries, I believe. To date, we had about 2,900 participants took advantage of this freely knowledge-sharing Summary Institute. That Summary Institute in some areas evolved into curriculum twinning. How can we really build the capacity of the partner universities rather than we always travel and teach you, not just giving the fish, but how to fish. So Dr. Armando Hoet, one of our key champions in veterinary public health, he led an effort with the World Organization for Animal Health and University of Gondar to establish a wonderful curriculum twinning program. Recently published a paper on harmonizing the veterinary curriculum, and really a great project already making impact on 11 veterinary colleges. More details of this same process, really the curriculum twinning and how we started. We engage the government, whichever country we work in. Ministry of Education was at the time in Ethiopia, and Ministry of Agriculture, because that is accrediting body for veterinary medicine curriculum. We had multiple colleges partnering with this, particularly College of Veterinary Medicine and Public Health from our side. So here are some of the champions. Dr. Desalegn, whom you will see perhaps later on, our Associate Director, former President of the University of Gondar, is a great leader in academic capacity building training. Dr. Besesi, Dr. Amanda Berian, and Dr. Armando Hoet. Dr. Armando Hoet is the PI on the curriculum twinning. So lots of impact and sustaining this program now the Ethiopian government, the Ministry of Science, Higher Education, the universities are taking over independently to run this highly competent program. That's it. That's our vision of capacity building in one form. Another example, so applied research implementation capacity, is our rabies prevention control. Rabies is kind of an old disease in most part of the Western world, but still have a major burden, killing estimated more than 1,400, particularly children in Ethiopia. India, perhaps the largest burden in rabies. But still in many developing countries, rabies remains important. For us, it's not just about rabies, but we used the rabies prevention and control as a way to set up a One Health system to engage the various sectors, bring together the academic partners in Ethiopia with the Ministry of Health, with the Ministry of Agriculture, Environment, many others. When we launched this pilot project 2013, we ended up bringing about 13 also Ethiopian organizations, and then CDC, Ohio State, with the leadership of the Ethiopian Public Health Institute. Anything you do in capacity building, it needs to be led. The idea needs to originate from the country, not dictated by us, somebody from Columbus, Ohio, or anywhere else. I strongly feel about that. Having said that, definitely with a number of things happened on rabies. Here are some examples of sustainability and metrics. Right now, in fact, we were way past this. In the last 2 months, I think we passed 65,000 dogs vaccinated, 223 surveillance officers, a number of achievements. But more importantly, again, that same system relationship we built for One Health is helping now taking care of COVID-19, including the establishment of our own regional office based in Addis Ababa, Ethiopia. And here are some examples of the champions. There are a long list of people, but Dr. Laura Binkley, who moderates our webinar here, Dr. Getnet Yimer, whom you will see later, our regional director, Dr. Getnet Quinn is a subject matter expert veterinarian. Even within Ohio State, we brought at least about 7 colleges because we needed many people. For example, College of Business. How do you develop the supply chain of vaccines, logistics of vaccines, things like that? None of us veterinarians, physicians, we cannot know it unless we bring in business experts and supply chain experts. A little bit further into, again, applied research and laboratory capacity building. Here is an example of a program from our NIH Fogarty International Center. What we named as this program is called One Health Eastern Africa Research Training Program. It's been a very rich program, really building the capacity, especially in molecular epidemiology of infectious diseases. We started with foodborne pathogens. It evolved a number of waterborne, vector-borne diseases. A number of trainees graduated in this program, and currently some of them involved in COVID-19 diagnostic in their respective countries. And our fellows, through additional partners, get trained on bioinformatics, genomics, and so on. So this program is co-led by a number of my colleagues from Ohio State, but also from Kenya. Dr. Sam Kariuki is the co-principal investigator, not indicated here, but Dr. Sue Wang, you see in the middle, and Dr. Michael Besesi. From 3 of us are from 3 different colleges on Ohio State side, but great partners in East Africa side as well. About 11 PhDs graduated. Again, some of them are doing COVID or other work, waterborne, foodborne work. Some are in fellowship right now, like Mr. Dabasu, who is a rising star PhD fellow currently. He is in one of the world-renowned labs, Dr. Linda Saif and Anastasia's lab, studying coronavirus. By the way, the decision was made before COVID-19, but as a coincidence, now we are in the midst of COVID-19. So Dabasu, upon his return in a couple of weeks back to Ethiopia, he will be instrumental in COVID-19 investigation, working at the University of Gondar, but also producing the future cadre of researchers in coronavirus and other related enteric and respiratory viruses. More examples. So this is again on the NIH part. We started with, as I mentioned, food-borne pathogen, but expanded to waterborne and vector-borne, and now, of course, COVID and others. It has a number of components, laboratory as well as field components. I'm very thankful that we expanded our partnership last year, besides the NIH, with two organizations. One is the Chan Zuckerberg BioHub, particularly with genomics and bioinformatics training directly in East Africa, but here at Ohio State, all of these pictures are before COVID-19, okay? Social distance, mask, that was not in our radar screen. So these pictures are taken before COVID. The other partner, wonderful partner, is the Genome Tracker Group, led by the US FDA in Maryland, but doing great work with us in Brazil, Mexico, East Africa, particularly in those areas, but also Thailand with Chiang Mai University. One of the focus and near and dear to my heart is antimicrobial resistance, a major global public health crisis. It is a public health crisis designated by the United Nations Interagency Group back in April 2019. This remains a major issue. It does not kill thousands of people a day or something like that. Unlike an acute pandemic, for me, antimicrobial resistance is a chronic pandemic. By 2050, it's estimated to have a burden of $10 trillion and 10 million people dying each year from the world by 2050, majority from Sub-Saharan Africa and Asia. So be ready, but we need to be very much mindful and try to slow down the acceleration of antimicrobial resistance. And we're doing the best we can, producing a cadre of scientists on antimicrobial resistance. If I'm taking too much time, let me know, Laura. Okay, feel free to interrupt if I run out of time. Do not really time myself. Okay, everyone.
Yeah, no problem. Yep, you've got plenty of time.
Okay. Implementation capacity, another dimension of antimicrobial resistance besides the core research and applied research part is the clinical part, the antimicrobial stewardship and diagnostic stewardship. That is as part of our global health security agenda in partnership with Ethiopian Public Health Institute, Ethiopian Ministry of Health, as well as CDC, the US CDC. We have been training of the trainers, the future trainers on antibiotic stewardship, appropriate clinical specimen collection, and so on and so forth, because that diagnostic capacity, infection prevention control, IPC, is critical aspect of preventing or slowing down antimicrobial resistance. Here is one of our wonderful champion scientists, Dr. John Miguel Baladalasat, and one of the master trainers from Ethiopia. And these master trainers, we observe them. You see Jennifer Q from our group on the back and Kathy Gallagher from CDC observing those master trainers, further amplifying what they are trained and training their colleagues at the hospitals, nurses, pharmacists, physicians, and others. Here is Jane Q, Dr. Kurt Stevenson, a key leader also in this aspect of our global security agenda, and Dr. John Miguel Baladalasat indicated. So we really achieved a number of things. Still, long way to achieve. Really, to be happy. We're done. There is no we're done, right? There is a lots of problems still remaining, but we were able to develop one standard clinical specimen collection manual for the nation. It's distributed throughout the country. That's what I heard. But also, interestingly, this manual has been asked by Kenya, by the government of Zimbabwe, by other Middle Eastern countries, which already making impact in the continent and in the region. Besides just, it's not this project in Ethiopia is not just for Ethiopia. It has impact on other nations as well. Clinical trial vaccines diagnostic capacity. Dr. Getnet Yimer is a clinical trial expert himself and pharmacogenomics PhD and physician scientist. That is a great lack of appropriate clinical trials, both in human medicine, but also study designs in veterinary medicine and zoonotic diseases, randomized controlled trials. Other designs are very much lacking behind. So we used an opportunity for a USAID project on tuberculosis to build a clinical trial capacity while testing a new regimen for tuberculosis testing in humans. Another dimension of the TB testing we also do is on Mycobacterium bovis and rapid diagnostic systems that we adopted, our wonderful scientists adopted from human medicine, modified the necessary things modified at Ohio State and Texas partners in San Antonio, and then implementing it in different countries, including United States. Tested it in Michigan, where there is Yimer bovis, tested it in Texas. Dr. Sue Wang is a champion on that from our side. She and I went and tested it in Mexico City, outside of Mexico City, in dairy farms, and in Ethiopia and many other countries. This has been really a great, wonderful global project and high impact project. And this clinical trial capacity and related issues, vaccine development, which I don't have time to go into detail. Another champion is Dr. Rabies from our GEMS Comprehensive Cancer Center on Epstein-Barr virus, non-Hodgkin's lymphoma, which is understudied. Investigations are developing world in general, but also training the future cadre of researchers on vaccine development. What do you go about? This partnership includes the Center for Drug Discovery Therapeutics Africa, CDT Africa, also based in Ethiopia, but includes about 6 countries. There are additional new projects, relatively new projects. I don't have much results to share, but on enteric dysfunction, a couple of years ago through Gates Foundation funding, we started Campylobacter genomics and enteric dysfunction. It involves children, chicken, Campylobacter, the organism, and building capacity for the region. This is a partnership with Haramaya University and University of Florida, the primary organization that leads the project. Ari Havelar is from University of Florida. That evolved about a couple of years ago, what we call TARTAR. It's a food safety project led by another champion, Dr. Barb Kowalczyk, co-principal investigators, Rob Sharf, Ahmad Youssef, many other great scientists with Barbara, that they are leading, investigating Salmonella, E. coli, Campylobacter in the food systems in Ethiopia, developing a risk ranking system, and informing the government how to take care of food safety. Another wonderful One Health project and highly needed in Ethiopia, both in beef and dairy. The 2 targeted areas are beef and dairy on the Tartar project, whereas chicken are in the caged project. Recently, Dr. Kowalczyk was successful to expand that project to Kenya with our partners at the Kenyan Medical Research Institute, our own NIH fellow, postdoctoral fellow, Dr. Robert Onsare, as co-principal investigators working with her. So I don't have much details on this project. COVID-19, lots of great work we are doing and increasingly accelerating work. The pandemic is accelerating, as you know. We should not be complacent. It is increasing in most parts of the world, perhaps throughout the world, but we are doing lots of work. So I will just leave it with that for now. And maybe during the discussion, Dr. Getnet will address more, but we're doing lots of great work on active surveillance, contact tracing, risk communication. We completed non-pharmaceutical intervention work. We completed research prioritization for IPC, PPE, provision in a number of other areas on COVID-19. And implementation on COVID-19 is continuing. We are just finalizing a new cooperative agreement with CDC to launch a major project on COVID-19 and other influenza-like illnesses, severe acute respiratory illnesses. For that, we have other great champion scientists, such as here is a virologist, genomics, bioinformatics expert, Dr. Zalal Makouria, who himself is now a PI on a new project, including what I'm not going to have time to mention, but also on working on acute febrile illnesses with Department of Defense Threat Reduction Agency, DOD, DETRA, and other colleagues from arts and sciences on data analysis, sociologists, a number of multidisciplinary team is involved, internal medicine, and indeed our wonderful regional office. Not much time again, but Genome Tracker is a project I already mentioned, FDA-led. We have been great partners, including Ohio, Africa, Asia, Latin America. We did more than 1,100 now, whole genome of Salmonella sequenced by the FDA, uploaded on NCBI website. A number of our former PhD fellows from Tanzania, Kenya, Ethiopia, Mexico, Brazil, and Thailand did their work on that. And we're doing now, slowly but surely, we're slowed down by COVID-19, but doing a global genomic analysis of MDR Salmonella through this project. So I'm happy with this project. As part of our outreach community engagement extension project, I mentioned to you, we do a number of events since 2007, even the precursor of GOHi we've been doing with Brazil originally, with Kenya later on with Ethiopia, Thailand. We did a number of workshops throughout the year. But our key flagship programs, as this is GOHi 2011 from United Nations Conference Center in Addis Ababa, that attracted, I think, 45 or 50 countries, more than what we expected initially, thought of a regional conference. But the issue is very important, particularly bringing developing country scientists or developed world scientists is challenging. Many meetings I go in the last 23 years in 2 academic universities in the US, many places you go, you see lots of Europeans, US, Canada, you know it, and any of you participating from US, Canada, Europe on this webinar, you know it, but very less developing country. You see some travel scholarship, a couple of Africans working this way, or some Asians this way. That should not be the case. We, GOHi, believe that we have to have a platform where we bring in various developing country regions, Sub-Saharan Africa, Asia, Latin America, we brought those together, and we are more of the minority. We means from US, Europe, others, but bringing south to south, but also north to south. So that is our motto for the GOHi conference, Global One Health Conference with its new name. And targeted conferences like this one is from end of October 2019, about 60 days before COVID-19. We, together with the NIH Fogarty International Center, GOHi and NIH organized a health capacity building conference in Ethiopia, attracted 35 organizations, 7 US universities, Emory, Columbia, some others are even co-organizers with us, and a number of great partners, including Dr. Francis Collins, Roger Glass, many NIH leaders, APLU Vice President, many great partners, really bringing particularly Ethiopia, but the Eastern Africa partners with NIH and Ohio State. And the discussion was, how do we build capacity to prevent future health consequences, such as pandemics and other chronic disease, acute diseases? And long and behold, within 2 months, this pandemic broke out. So this is critical challenge we all have down the road in the future. And I would like to thank our wonderful organizers here listed here. I already mentioned Ashley Barsani earlier, Tegistan Dashaw, our regional program manager, another great champion, Dr. Sania Ilik, great outreach extension colleague, and our director of outreach and community engagement, Dr. Amanda Berian, who now chairs the Global One Health Conference, which will happen summer of 2021, originally planned to be physically face-to-face in France, but of course, as you can imagine, most likely it will be virtual. Overall, just to summarize, GOHi, our principle, we have our approach, as you notice by now, it's integrated, translational. There is lots of knowledge in the developed world. How can we have equitable knowledge? Share this knowledge to the other parts of the world, have the whole world to benefit from it. We have a multidisciplinary approach. The world is a very complex one. We need a collaborative, transdisciplinary approach. There is no question about that. Anything we do is mutually beneficial. We as a university, we're not donors, as sometimes people perceive us. If you come from US, you have money or something. It's not like that. It's not donor-recipient relationship. Our students benefit, our faculty benefit from this partnership, just getting their horizon of knowledge. That's hugely beneficial to US students and academics alike. The same thing we give back. we make impact on the ground. We work things very efficiently, and we have a great resource stewardship. We, as much as possible, we build equity of our own staff. You see some gender equity data here from our staff members. We do empower our staff members in different leadership trainings and other things. And definitely GOHi is wonderfully, really growing tremendously. I think when we formally started launching GOHi 2016, about 8 of us between 2 offices, Columbus and Ethiopia. Now we have more than, I don't know, 96 or so between the 2 offices employees. But we'd like to have to build that equity and empower our team and be a model for others, be an example, a good example for others. So yes, as I just mentioned, we have a regional office based in Ethiopia that serves Eastern Africa. This is our provost and the state minister of science, higher education, state minister of agriculture. Inauguration was in 2017, but we launched in 2016. We have incredible multidisciplinary team of great scientists as well as administrators in that regional office, and very grateful. Lots of our wonderful success happening today and in the past is because of their unreserved efforts. I'm also very much thankful throughout the years since we started small but expanding as global work, particularly since 2019. All of these organizations took part, either in kind, some of them, but majority of them providing financial resources, extramural funds, typically competitive funds to make our goals into realization. So I'm highly confident we all together, we can build, expand, strengthen, sustain really a vibrant global capacity. Let's really prevent the future, whatever COVID, another year. We don't want to see another pandemic. Most likely it will happen. It's not going to wait another 100 years, but let's do the best we can together to build capacity to effectively prevent and mitigate any potential epidemics, pandemics, antibiotic resistance, chemical hazards, cancer, you name it. So thank you so much for your attention. Muchas gracias. Amasaganalo.
Thank you so much, Dr. Gebreyes, for that wonderful overview. And I would now like to introduce Dr. Getnet Yimer Ali, who will be joining us for our panel discussion. Dr. Getnet is a physician, PhD holder, consultant medical specialist, and regional director of our Global One Health Eastern African office in Ethiopia. Previously, Dr. Getnet worked for 7 years as a consultant on TB/HIV clinical trials for WHO TDR, in charge of leading and coordinating activities throughout 6 African countries. Getnet is also a member of the Ethiopian National Health Research Ethics Review Committee at the Ministry of Science and Higher Education and the National Drug Advisory Committee at the Ethiopian Food, Medicine, and Healthcare Administration and Control Authority, as well as chair for the National TB Advisory Committee in Ethiopia. And we also have our Eastern African Office Associate Director and former president of the University of Gondar in Ethiopia, Dr. Desalan Degafo, joining us. And with that, I will go ahead and get started on our panel discussion. So we ask that you please send any questions through the Q&A box, and we'll go ahead and get started. I can go ahead and start us off with a quick question. So for everyone on the panel, partnerships are a critical, they're critical to Global One Health implementation. How do you go about identifying these critical partnerships and then initiating them?
Happy to start, or Dr. Getnet, you want to comment?
Anyone
first?
can jump in.
Yeah, I think, thanks very much, Laura. Thanks, Dr. Gebreyes, for a great presentation. Your question is really, it's a wonderful one. Partnership, you can have a lasting partnership. As we always say, a partnership that really makes an impact on the ground. Selecting and getting the real partnership is something that we all need to work very hard if we want that partnership to really last longer. In the presentation, you have heard examples of different deals. And for most of those projects that we're involved in, you have seen that we start by doing a baseline assessment, the existing baseline. That includes assessing who could be our potential impactful partner on that area, who could be a partner. We can tell you that we have had partners where we signed MOUs, we have had partners where we have agreements, and we have had partners in different parts of the world. With some, we have managed, in fact, with most of them, we have managed to make a significant impact. And as we always say, in the partnership, because if you see the core of One Health is all about partnership. And it's also a practical, a very practical, pragmatic, adaptive kind of partnership that we want to have. Engaging from the top leadership up to a grassroots level implementers. So we count a lot on a partnership. From Dr. Gebreyes' presentation, with all this impact in the last, number of years, some of you may think that, okay, GOHi has like this big skyrocket building in the US and in Africa. That's not how everything worked out. It's mainly because of the partnership, because of the practical working partnerships that we built on. We use, for our different trainings that we had, we use a partnership with EPHI, the National Training Center. For a number of activities, prioritizing on the Ds that we work, we count a lot on, be it international, local partners. And yeah, let me stop there, and perhaps Dr. Gebreyes may reflect on that.
Yeah, can I also reflect before Wondwossen? Yeah.
Yes, please.
Thank you, Laura. Yeah, thank you so much, Laura, for raising a very important issue. And Wondwossen, thank you so much for the report. And just, partnerships, I remember when Wondwossen visited the University of Gondar in 2009. And we had a discussion regarding possible collaborations. And that time there was, Wondwossen was mentioning about the mutually beneficial partnership. So the interest was there from the US side as well as from the Ethiopian side. And we have been, we need to have a commitment from both sides. It's not a matter of, we expecting some kind of funding from the north without, working a proposal together, or without committing ourselves from the south. He was also mentioning about, donation. It's not a kind of donation. Many people may expect partnership as a kind of donation or charity. It's about, working together for a common goal. So there should be understanding that, even the funders, whenever we are getting funding from the funders, we are working with them to achieve their goals. It's not, getting money for any kind of charity. So there should be, everybody should understand that collaboration or partnership is mutually beneficial. There should be a commitment from both parties. Sometimes there are, MOUs and memorandum of agreement signed, but nothing is done, after the signing. So as Getnet also has been also mentioning, there should be a commitment from the grassroots to the top leadership. Otherwise, usually whenever, partnerships are lying on the top leadership and they are not going to the faculty, there will not be a kind of faculty to faculty from north-south kind of partnership. The leadership should create opportunities for faculty to introduce to each other, to work together so that they can identify a common area of interest. They start proposal writing, they do, project and together. So from my experience, from Ethiopian context, Usually many people in Ethiopia, they expect somebody from the US or Europe to bring a project down to Ethiopia without even working, without identifying a common in the area of interest and without working together. So partnership could be very strong and sustainable whenever there is a commitment from both sides with a very common goal. So this is my reflection. Back to you, Laura.
Excellent, wonderful, excellent points. Thank you. And then Dr. Gebreyes, do you have anything to add to that?
I think it's very well said. This is our principle, as both Dr. Getnet and Dr. Dessalin articulated. That's exactly our principle. I really nothing to add. Very well said. So.
Excellent, thank you. All right. Again, if you have questions, if you could just send them in the Q&A box. If not, I have plenty.
Go for it.
Okay, so I will go ahead. So what are some of the greatest challenges to Global One Health implementation, and how do you approach those challenges?
Yeah, when you build a program, there are always challenges. So let me start, but definitely my colleagues will have more to say. In any partnership, I think partly maybe to start with, as Dessalin commented, is really the expectations need to match, need to be compatible. That perception, if that's from the get-go, unless you really clarify and make sure the perception in both sides of the partnership is clear, it could go in the wrong direction. If the partner's expectation from a US organization is XYZ, or likewise the same. You take a faculty member from YSU to be it in Africa or Latin America, and the expectation might be not matching. So it's really a continuous capacity building is really a continuous process of that, also matching that expectation. So it is partly a challenge to navigate that and ensuring and establishing a smooth, mutually beneficial, sustainable partnership. Second is communication, from small type of communication to high level communications. Often very subtle things could disrupt partnerships. And often the style of communication, the level of and the efficiency of communication from countries to countries vary, particularly in establishing international programs. Communication could be in many different ways, could be challenging. The third is, it's been said already again, but overall resources, particularly financial resources. You may have great scientists, great committed people on both sides, but resources more and more are highly competitive, you have to be very creative. You have to be outstanding, not just excellent. Excellent is no longer good enough in the US funding system. I see some of the names here. I'm sure Dr. John Gunn and many other people can witness. When you go to NIH, with a pay line of 10-12% of the proposals getting funded, the remaining 88% not funded are excellent. But you have to go beyond excellence. So that getting that mindset into both sides of the partnership could be challenging, and overall these resource limitations. But as Dessalin said, also the expectation should not just be sitting and waiting for a project is very dangerous. It's really, they can never have an effective, sustainable partnership with that mentality. So everybody needs to work hard towards a common goal. So those are the three things I can think of.
Yeah, perhaps a couple of points that I may want to supplement. Thanks again. And indeed, some colleagues were asking us, why now? I mean, when GOHi opened office, while the global resource is declining, and a number of challenges were anticipated when you set out this kind of international program. I would love to say that as long as you have the right vision at the right time, and you might have noticed the right team that we keep on building our own team, the appropriate partner for what you want to work on, and you deliver on the vision that that you have. I would say that even if there could be challenges here and there, as long as you have the vision, you start solving the challenge from there. As long as you have the right team and the right partners, you start solving most of the challenge. But it doesn't mean that, it has been smooth all the way, everything that we do. But we count a lot on, as the saying also goes, when you do a bike, when you do a bike in a mountain, you don't see the top of the mountain because you fail. You keep on dialing. You may have challenges as you move on. So that's our principle. We have the vision. We all share that vision. We try to build our own team to solve some of the challenges that we face. And along the road, we build great partners who help us also sustain what we are there for. In fact, since some colleagues here are also our fellows, I can tell you that most fellows that were part of GOHi before are our partners now, are our colleagues, and they're in our network. And it's mainly because they believed in the vision. It's not because we never had challenge. So let me stop there, but that was a wonderful point again, Laura. Thanks.
Yeah, maybe a couple of points from my side. In Ethiopia, just from the Ethiopian context, the experience, that I've been working in one of the Ethiopian universities at the University of Gondar. Before, Anderson visited our office and discussed about, global One-Health, most of the disciplines, we do have in Ethiopian higher education, there is a traditional territory between disciplines. The chemist working, only with his team, the people from the College of Health Sciences, doing only, establishing a team by their own. Even it has never been, the College of Vet Med has never been working with the College of Health Sciences and, from social sciences, from agriculture. So there is a territory in Ethiopia, in the context on the ground, there are, professional kind of territories. People are not working together, but the problem is very complicated. We are not following a kind of, integrated approach. So, global One Health, the concept, that we started, since we start working with Ohio State, the establishment of the concept, global One Health has brought many people. I remember whenever we established a One Health steering committee. So people from veterinary medicine, from agriculture, from public health, from medicine, from different departments, we established a committee and they started, working together, preparing workshops, seminars, so that then after, later people understand, the importance of working together on One Health and, kind of multidisciplinary. So we changed our research policy into a multidisciplinary problem-solving kind of policy. So that brought us to understand working together is very fruitful. So before that, still it exists in Ethiopia. There is a professional kind of territory. People were not working together. So this is a big challenge. And, global pandemics like coronavirus, is an opportunity also, before that, the United States stands first in the Global Health Security Index, maybe, but now, people understand, the gaps. So it gives you to identify the gaps and to work on the gaps together. Getnet was mentioning is a challenge, getting funding, but it's also an opportunity to fill in the gaps that we are seeing in global pandemics.
Just to add a minor point, but already said, just to emphasize, again, over the summer, we had a silo effect. Mostly organizations are highly siloed. Again, it's not specific to a country, but in the US as well. in the university settings, while you respect the administrative boundaries, One Health is cross-cutting, right? But even physically, let's take University of Nairobi. You have a central downtown Nairobi campus, lots of the social sciences. You've got the Chiromo campus, where you have the environment hazards. You have Wayfar's Upper Kabete campus, where you have agriculture, veterinary science. It's so siloed with a distance. The same thing you see in many US universities. The same thing is the University of Gondar. If you go to Ethiopia, engineering campus is here. Even the situation is not conducive. Even you want to adopt a curriculum, you want to give genomics for multiple colleges, veterinary, public health, even some engineers, biomedical engineers can take genomics, but it's very hard. Starting from the physical infrastructure, it creates a challenge. So, I mean, there are many challenges, but that silo mentality, starting from our mindset, is siloed into the physical infrastructure. Siloing is a big challenge.
Thank you. You both read my mind for the next question, but I'll still read it in case anyone has anything additional to add. My question was, what suggestions do you have for getting multiple sectors that are often siloed to work together? So if you have anything additional to add to that, but I think you've both addressed it as well. And if Dr. Getnet has anything additional, I'll give you a chance.
I think, thanks very much again for bringing that up. The reason why I keep on repeating why GOHi is a very practical, office and is mainly because if you see us, the dynamics, not only the gender balance that was shown on the graph, if you see the professional mix between public health, human health, veterinary, and the way the directorship is set up, we want to be a model for what we do and what we believe in. So again, Laura, even if all steps, really matters, leadership and the vision takes the higher share. And we have noticed as leadership changes in the countries, in the institutions, the way things change in implementing One Health across. So the model that we follow from our mix, and obviously the different things that that I just mentioned could be wonderful and exemplary. Indeed, that's a major challenge. As you know, when GOHi came in, even the idea of One Health wasn't that much existing. It was there in some area, but it wasn't, growing that much fast. But if you see now, lots of people are, interested in pursuing their career, in building their capability. Institutions are even taking example of the Ethiopian National One Health Steering Committee. The team keeps on growing. Now we have Africa CDC in it. We have WHO in the team. So beyond even the typical examples of the ministries, interest globally is growing, and that's the way forward. Thanks again for asking that question. Be practical. Thank you.
Thank you so much. Such great answers and wonderful advice. And so I guess my last question will be, unless anyone has any additional questions, in general, what additional advice would you give to those working to build global One Health implementation as a career? I think you've already provided a lot of wonderful advice, but if you have anything additional.
Yeah, I can reflect on that. One of the issues in advancing global One Health is the issue of curriculum. Wondwossen was trying to mention, in Ethiopia, for example, I'm mentioning Ethiopia just because of my experience in higher education. The curriculum is very, very structured, it dictates, you cannot go from college to college having elective courses, and even universities are not in a position to change the curriculum. Nationally it gets harmonized, and only there are a few rooms, like 10%, sometimes 15% of room for the universities to revise the curriculum. So if that curriculum during harmonization, harmonization means, making the curriculums from different universities just a uniform kind of curriculum, usually for, advantage for student mobility. But, the problem with that is, the world is changing, climate change is coming, lots of issues, global warming, lots of new issues are coming. But if the curriculum is not responsive enough, the students graduating from the universities will not be able to be responsive to the world dynamics. So curriculum is one of the most important issues that, we have to make sure that, curriculum is dynamic. We have to change the curriculum so that our graduates, undergraduate or postgraduate, whatever, whoever will be graduating from that curriculum will be dynamic in their thinking, in academic experience, whatever. So just wanted to raise the issue of curriculum, and we have to make sure that, higher education leaders give due concern on curriculum dynamism. Thank you so much. Yeah.
Laura, perhaps, last word on this one. What GOHi really believes in for whoever wants to start an initiative like ours is perhaps asking the 5 major questions on what do I want to do, the why do I want to do it, where do I want to do what I want to do, how do I want to do it, and how do I do that. For us, the what part came first, and obviously from the different example that you saw, our major focus was the most neglected area that if you see the food safety, the waterborne, foodborne, vector-borne diseases that we were engaged in. And it wasn't only the science, something that we didn't focus a lot on today that we'll be sharing with you all maybe at some point in time is we also work a lot on the soft skill, developing the soft skill, because we consider the skill, we want to have that comprehensive. The where part really matters. Dr. Gebreyes mentioned Brazil, Mexico, and other. For us, even if our principle is still mutual, we still select on where can we make that impact, the utmost impact. So you have to make sure, again, whoever wants to engage on that one. And the when piece, we follow as GOHi an adaptive model. When COVID came, we were the first organization to jump in and do the NPI. So when do we want to engage in different activities? At times we sacrifice and we take risk. And obviously the why and the how part, a very good example given on the proposal example on how to catch the fish is our model that we really want to follow and we really engage on. Again, we believe in giving beyond the projects that we have. We're engaged in different committees nationally, making impact beyond the different projects listed there. So if you ask those questions and come up with a wonderful idea, avoid the scarcity mentality, as we always say, the sky is the limit and you succeed. Thank you. Dr. Gebreyes may want to add.
I think it's been well said from the pragmatic, practical point of view, as both Dr. Desalegn as well as Dr. Getnet said it. But for anyone, with a broader question, maybe, Laura, if you are asking, how can one in the world be inspired to, the inspirational part towards working global One Health areas, that intersection of human health, animal health, environment, plant health, any of that interface is really being curious and living in this world is sufficient, right? On the New Year's Day, if you all watched the news, 371,000 babies were born. UNICEF reported it, especially from 10 countries. 5 of them are from Asia, 4 of them Sub-Saharan Africa, and the last one, the 10th, is the United States of America. These 10 countries compose 50% of the world that the babies born on that day, and the 50% to be born in this year. In 2021, the United Nations estimate is 140 million people will be added on this planet. That is more than 1/3 of the United States of America. We are about 328 million of us, right? So yeah, close to getting to half, maybe, you know, about 40% or 35%. That's a huge number of people, babies added every year to this planet. So then the related impacts, the land use pattern, urbanization is going out of the roof, you know, 55% now living in urban, and climate change. And we live in a highly interconnected, interdependent world, and more obvious. So for any scientists in any part of the world to be one way or another, regulatory issues in capacity building, in research, innovation, to do this interface of One Health, the case is made by the planet itself. The planet made the case for us. Now, the practical part is really what has been said already and excellently articulated by the Sally and Getnet, be it on curriculum design and really getting everything lined up to answer those 5 questions. But you have to, as an organization, if you are establishing a program, I was invited by some group over the weekend and giving a talk how to establish a program. First of all, that why do you exist? What that organization exists? You have to really answer that question, and then the series of questions getting that outlined. So thank you.
Excellent, wonderful answers. So I guess I'll give everyone a final chance to either ask questions or our panelists to make any final comments, if you have any. And
it's been very quiet, audience. Any questions, audience? Did we confuse you? I don't like it when people are too quiet. That's a problem. Yeah, but you had an excellent questions, Laura. Thank you so much.
Thank you. I could ask all
if there is no question. Yeah, if there is no question from the audience, definitely. I mean, this has been great and really great New Year. This will be a wonderful year. We will really take care of COVID issue together. You know, the world. I think somebody's raising a hand.
Yes.
So maybe give a chance to, hey, Joseph Nguta from University of Nairobi.
Right. I will go ahead and unmute you, Joseph. You can go ahead and ask your question.
Thank you, Wondwossen and the team for the presentation. You have just talked about the islands in terms of One Youth research, giving the example of Upper Kabete campus, Faculty of Veterinary Medicine, where we are doing our own things, College of Biological Physical Sciences, Chiromo, doing their own things, School of Public Health in Kenyatta, doing their own things. What's your advice? How can we bring this concept to one table? Because we all have different interests. We are working towards ensuring that all these pandemics are prevented from the environmental side, from the veterinary side, from the human health side. Thank you.
Thank you so much, Joseph. Yes, that is an excellent question. Yes, we physically, just like other organizations, I give University of Nairobi as an example, is highly siloed. But the key thing is more than that. The mentality is, just you said it, we have different interests. I think that is a problem starts there. 2016, I spent quite a good few weeks of my time in Nairobi and working with all of you across the campuses, working with Cambry, working with Calro, bringing DVS, Division of Veterinary Sciences, bringing ZDUs, Zoonotic Disease Units of Kenya, coming to ILRI. Some of the ILRI people who are in Upper Kabete, I don't know if any ILRI person is here, you can speak up, have never been to right Upper Kabete. You can almost walk it to the veterinary school. They have never been until that time. We purposely rotated the workshops. Intentionality is good. We purposely rotated the workshops between ILRI, Upper Kabete campus, Chiromo, Cambry, way down on Ngang Road. So that intentionality, number one, aligning your interests. If everybody thinks our interests are different, you are strengthening the silo. But the world tells us, the planet, COVID-19, or be it any case, AMR tells us 65 to 75% of emerging infectious diseases on this planet are at the interface, right? Of animal origin getting to humans, be it Middle Eastern respiratory, so many of them, you know it already. Vector-borne disease, Rift Valley fever, and many others. And has been Bruce Kahn articulated it last time in a wonderful webinar on this webinar. So we have much more things in common, the Chiromo campus to work with Upper Kabete and with you, the different campuses, even across your sectors, ZDU to work with you, DVS, Calro, Cambry, than what is our interest. There are some things you do just interest of veterinary medicine. Let's say your clinical science department, I think Joshua Animo, for example, is in that department, doing clinical work may have nothing to do with Chiromo, does environment, great climate change center in Chiromo campus. But there are focus on the commonalities. My advice, this is a long way of answer, but my bottom line advice, Joseph, you are one of the great champions, get the various campuses together, focus on the common alignment, be it a zoonotic disease, be it a foodborne, vector-borne disease, or environmental chemical hazards of at the interface. Then once you have that commonality, that vision, the why do we exist will come in. We had a great progress during those few weeks I stayed in Nairobi, 2016, I believe, between May and June. But that continuity, I'm not sure. But I think, just few champions like you can bring the community together, focus on the common denominators, which are many, and then really even out of those select areas to further strengthen. And we are always happy from Ohio State Global Wannels Initiative point of view. When I came at that time, I was just from Columbus and we didn't have a regional office. But now you have a regional office next door to you. So I think you can do a great work. Thank you, Joseph. Excellent question. I think this question, Joseph's question, many organizations, not just University of Nairobi.
Thank you. Thank you.
Excellent. Thank you so much. All right. Any additional questions? Comments?
Just a couple of points on Joseph and Dr. Gebreyes' reply. A few years ago, we recognized Kenya as one of the leaders when they established the zoonotic disease unit at higher level, bringing together different activities. And we were, globally, we were really giving Kenya as an example. Also recently, the government working with WHO and others, we have seen the NAPS exercise, the core of which IHR and working together, obviously, as has been said earlier, implementing global one doesn't mean that you need to be one. It doesn't mean one. So I would say that all this, unless it's complemented with the pre-service education, in-service alone doesn't go anywhere. What you asked now is really pertinent. And we are seeing now requests from different universities, at least in East Africa, that universities have started opening up departments, graduate program that works on avoiding those silos. So great question. The academia is where it should all begin, the in-service one. We have to continue working on the in-service as well, the pre-service, in-service combined. And Kenya building on the ZDU would be will continue to be an example for most of us. Over.
Excellent. Thank you. Well, if we have no further questions or comments, Thank you so much, Dr. Gebreyes, for your wonderful presentation, and Drs. Getnet and DeSalin for your wonderful, excellent panel discussion. Such wonderful lessons and advice to take away for Global One Health implementation. So we greatly appreciate your discussion. Our next webinar will be on Thursday, February 18th, and I will be following up with details via email and updating on our webpage. Thank you for joining us, and we hope you have a wonderful rest of your day.
Laura, before you close, I mean, there is a question from Nugusu.
Yes, I see. Yes, thank you. So,
okay.
Thank you, Nugusu, for your question. We'll go ahead and get that read. So, this is Nugusu Fasil from Ethiopia, Awasa University, Faculty of Veterinary Medicine. Thank you for your vital role and contribution. Is there any active plan considering in the development vaccine related with bee tuberculosis? Is it bovine tuberculosis?
Yeah, the bovine tuberculosis. Just so that. Yeah, obviously, Nugusu, thanks very much for the great question. And the quick answer for this one is, yes, we work on diagnostics. Yes, we work on vaccine, and we work also on treatment. When we prioritize our activity, we also see our results. And we have to also keep in mind that one organization or shouldn't address everything. If your question right now is, do we have a work on TB vaccine, bovine TB vaccine? The answer, the quick answer is no. However, we have got our vaccine portfolio is growing, and we anticipate that to grow even in the future, mainly on the post-vaccination aspect. We're working very hard. Like currently we have a very good work that we're working on adverse event following immunization, vaccination. We're working on second dose of measles and the uptake and the barriers. We're also working on, as shown in the slide by Dr. Gebreyes, led by Rob Bioki, our team. We don't know where that will lead, but we have a wonderful initiative on Epstein-Barr virus, non-Hodgkin's lymphoma association, HIV positive individuals. But who knows? I mean, that currently we don't have any TB vaccine, but in the future, we don't know where we'll be heading. I don't know if my colleagues want to supplement.
Yeah, not really. Our primary emphasis, a big problem as a veterinarian myself, as we know, in Ethiopia or Michigan or other places, really the rapid diagnostics and test and cull is a critical need, and that's where we focused on that 20 minutes rapid, cheap way of testing using urine from cows or milk. And that's where we focused our emphasis. But the rest is, as Dr. Getnet said, again, we are not, Global One's initiative by itself is not a discovery or a innovation or a research organism, right? So we are building capacity using adopting technology. So there is no an easy vaccine to adopt and test or do it in Ethiopia, but there are good diagnostics that you can adopt. In fact, the first, just to tell you quickly, the story how we got into that project is, over a lunch when we had NIH fellow, I think it was Binyar Obanda from Cambridge, having some internal medicine, our medical center, myself, the fellow, others over lunch, were discussing a TB issue and what they use at our medical center. And I asked them, you use urine in children? So they use the urine for children because it's not easy to get a sputum from children. And they use the urine on this quick testing. And they told me, yes, they get within 20, 25 minutes, they get tuberculosis. Then I asked them, has anybody tested this on Mycobacterium bovis? And nobody was sure. Well, let's check it. Maybe, maybe not. So Dr. Jordi Torres, who moved to Texas since, he quickly checked it, told me and Sue Wang, who were all doing on that lunch. And lunch here is a good conversation and a good productive time. Less on social. We always are very much stuck on discussing science over lunch. So he checked and he said, there is no bovine test, but I will be happy to test. If you get me some milk sample, we can spike it. So we got the bacteria from US Department of Agriculture. We got the milk. Easily you can get a milk from Ohio State Farm. Spiked it purposely, then modified it. Jordi, our wonderful microbiologist in the lab, modified the lipoarabinoids or cell wall parts of the mycobacterium. M. bovis complex is part of the TB complex, related anyways. The cell wall, after some trial, some modification, it started working with low sensitivity specificity. We took it to Mexico first with Sue and myself, with our partners at UNAM, Autonomous University of Mexico, tested it, got the results, improved it better, then got it into Michigan, Ethiopia, different places. So the long answer is, again, what we are trying to do is adopting an existing science with some modification to be able to make a global impact using this issue. So M. bovis remains really a big zoonotic disease. Diagnostic is a big challenge. So our emphasis on the M. bovis part so far is on the diagnostics part. Thank you.
Yeah. Since we have a couple of minutes, let me also supplement on that exact piece, the TB lamb. We were frustrated when we started long ago, but if you see the consolidated WHO guideline now for human, for the first time in 2020, WHO, besides the molecular assay, the expert and the expert ultra and the TrueNat, TB lamb is recommended for diagnosis of TB globally. And of course, the LF lamb is as well recommended, but this is the area that we are engaged in with slight modification. And we think that will make an impact by working on the diagnostics. And hopefully that will also be taken up by the OIE and other guidelines too. So I just want to add that because that was a major breakthrough, WHO recommending TB lamb. Over.
Excellent, thank you. And then we have a thank you from Nigusu as well. And all right, any further questions? Give everyone a couple minutes. All right. Well, okay, if we have no further questions, thank you again. And we look forward to seeing you in February, and enjoy the rest of your day. With that, we can adjourn, and thank you again to our wonderful speakers and panelists. Thank you.
Thank you.
Thank you, Laura, for great moderation. Thanks, everyone. Thank you. Getnet, everyone. We'll see you next month.